is recording now. I should very quickly just add as well that the information shared today is up to date as of today, the 10th of October, 2023. So I'm actually now going to pass you over to Priscilla, who will talk about the current research happening around endometriosis with EXPPECT. Priscilla, thank you so much for joining us again today.
No, thank you. Thank you so much for inviting me, Theo, because it's a great opportunity to touch with the community again and kind of like just tell you about upcoming research projects as well as ongoing ones that we have. And it's great that, you know, you're able to do that together with the charities, because obviously we require the help from all patients to help advance endometriosis research, and without the patients we couldn't do it without you, definitely couldn't. So I hope I'm going to be talking about 4 trials in particular, but other than that, I've got another 5, and so you know, it's going to be quite research heavy. So, and like Theo says, there'll be questions at the end, and if not, please don't worry. My email will be on the very last slide. Please take a note of that if you would like to get in touch after. If you perhaps go away tonight and you think, actually, I wish I could have asked that, or I don't want to ask that in a public forum. So I'm just going to attempt and share my screen, and let's see how we get on. So hopefully.
Looking good.
Okay, good, because Elon Musk is safe with his job. There's no issues there. Perfect. Can you see that okay?
Yeah.
Yeah, fab. I'm not going to reintroduce myself. So anyway, just wanted to let you know, we hope that, you know, patients' journeys, when they first have symptoms and then they get to a timely diagnosis and a tailored management plan, we would love it if it was this straight line where you have your first symptoms and then, you know, you actually get a name for it, the pain that you're experiencing or the other symptoms that you're experiencing, so that then someone says, I actually believe you have endometriosis, so let's, you know, do something about it and investigate it further. But unfortunately, I feel the reality is it looks a lot more like this, where you actually have your first symptoms, you do a bit of online research, you visit the GP, you might try hormonal treatments to see if that helps, you get referred to someone else, you might go to gynecology. And unfortunately in the UK, we do have a really long sort of diagnosis time of between like 8 and 9 years, depending where you live. So it really, what our aim with regards to research is to improve these diagnosis times, these diagnostic tests as well. And this is not obviously linear by any stretch of the imagination. And I think most journeys, unfortunately, are like that for patients who have endometriosis. And some of you may be waiting for perhaps, you know, investigations with regards to a laparoscopy, because that's the thing that's, you know, that's the procedure that's going to give you the answer definitively whether you do have endometriosis or not. Or you could be on your 16th endometriosis surgery. You know, it really, it's not linear at all. So I've put myself here as my research staff, the one at the very bottom, and sometimes when we as a research team want to approach patients in the clinical area, it can feel a little bit like this, where we're trying to get the information across, but it's sometimes really difficult. Clinical teams are really under a lot of stress, as you know. They may forget to tell you that there's this bit of research, but this is why we do these sessions, so that you're aware of the research that's happening. And I'm also going to talk about towards the end where you can find, you know, what the latest research is happening in your area as well. So sometimes we have to do a little bit of climbing to get to you, and sometimes you may need to do a little bit of climbing as well to get to us. So we try to make this as easy as possible, because of course we try and help you, but you're obviously altruistic enough to help us with all the different trials. So just to tell you a little bit what a research nurse really does, and you may think it's for us to sign on the dotted line, we need to get patients to sign, but in actual fact that couldn't be further from the truth. And what we do try to say and do is to actually inform you of the current research and that is happening, and actually give you the opportunity to participate in a research trial that you may be eligible for. And sometimes we do approach patients and then we have a little bit more of a chat with you, and you might think, in actual fact, this is not the trial for me, or I'm not in that, you know, at this moment in time, I'm not in a place in my endometriosis journey to participate in this. But, you know, as long as we've told you about it and you know about it, I think our job is done. And also, one of the things to remember, I think it's imperative to let patients know that this research happening in their area, so that they have hope that people are looking into a condition that can be so debilitating like endometriosis and chronic pelvic pain. So I think that's the main thing. And it could be that research at this time in your life is not for you, and that's totally, absolutely fine. We get a lot of patients saying, not for me at the moment, but I'll bear in mind, you know, and for the future. And I'm just going to go over some terms. If you haven't participated in research before, you may not know what some of the terms mean. So I thought I'd maybe just talk to you about it. So multi-centre just means that a trial is happening at various hospitals across the UK. It just means that there's just more than one hospital that research projects has been run at. We've got the term randomization, which basically means random, and usually this is done by a computer. So if we say that a trial is randomized, it means that a computer assigns you an allocation, whether perhaps, you know, it could be that you may have heard the term placebo controlled. So it means that one arm is the actual drug or supplement that we're trialing, and the other one is a placebo that's identical. So you don't know, and we don't know. The term double blind as well, which is what I'm coming to as well, means that we as clinicians looking after you in the research team don't know what you're taking, and neither do you. If it's blinded on its own, it means you don't know what you're taking as well. So the double blind comes from the clinical research staff and the patient not knowing. So just a few terms there just to actually throw in, because some of you may never have encountered research in your trust. So reasons for taking part, there's a few. Most of the time it's to help others. They don't want the person coming next to go through what they've had to go through in order to obtain a diagnosis, pain relief, etc., etc. And it's really, I think with regards to endometriosis, it's really clear that a lot of patients want to do this as well. For example, to help their daughters. People coming, they say it may not help me, but it's going to help other people. And there's a lot of research out there that is similar to that, where we say this may not particularly benefit you. For example, if you're completing questionnaires, that's obviously a burden on your time, but that's an observational type of research that we can gain a lot of information, and we try and collect as much as possible to understand the condition, better really. And then we have just touched upon that anyway, to add to the body of information available to patients. So it could be that we do a survey and we say X amount of people are experiencing these side effects and things like that, or these symptoms. And that's where we get all their statistics to give you from, and say, actually, pelvic pain is probably the most common symptom of endometriosis, but then comes the fatigue. So we know that for sure from asking patients like yourself. Obviously, it could be to receive a new treatment that's not yet available, that's been trialled at your trust or hospital, so to treat endometriosis, and I'll come to one of the trials, which is super exciting. And then to receive additional care and support from a clinical team. Nothing wrong with that. We get a lot of feedback from patients saying that they felt really well looked after because they've got someone they can talk to all the time and ask questions. And what you need to remember as well is us as nurses, if we are concerned at all, we always go to a delegated clinician, so a doctor who's really well versed in the trial itself, if we have got any worries whatsoever. And then lastly, of course, to help advance medical knowledge. There's a few types of research. The first one I'm going to talk about is about medication, and it's medical research, and that's, simple placebo or drug sort of thing. And then there's a surgical type of research where, for example, are we looking at a different surgical technique, or are we perhaps collecting samples during surgery to try and gather as much information with regards to the condition itself that then we take to the lab and we apply different things to, or we look at different aspects of it. For example, the different surgical trial at the moment that's quite big in the UK is called EXPPECT. You may have come across it in the past, but it's just looking at as to whether removing superficial peritoneal endometriosis is the best thing to do, or actually should we be looking at something else? So that's a type of that. And then we've got an observational sort of type of research where, for example, we collect questionnaires. We have smartwatches, like wearable technology, and then data linkage as well, where, for example, we would ask you for permission to look in the future to see, for example, things with fertility, and then we look at that, but obviously we would always gain your consent in order to look at your notes, etc. I put here a little sort of like sample research journey of what it may look like for you to participate. Now, every trial is different. And one of the things that I always say to patients is that, unfortunately, for a lot of the trials, the inclusion and exclusion criteria can be really, really tight. So someone may be really excited about taking part in some particular bit of research, and then unfortunately we have to say, unfortunately, based on what you're telling me, I'm not able to take you as one of the participants, and everyone's disappointed. But the thing is to remember, the inclusion and exclusion criteria is there for a really specific reason. We have to make sure that, one, we're not going to harm you in any way. And for example, if your weight was too low and we were going to give you a drug that was going to make you unwell, then that's why we've got like weight restrictions. And then also to keep the data as robust as possible as well. So when we come to publish the results, we say everyone had this, everyone had, you know, this other thing in the past medical history, and they were not, for example, diabetic or asthmatic or something like that. So it could be that, you know, these are all kind of like visits that we see you at, but more and more we're moving away from that, I think, a little bit, and we're doing a lot with regards to COVID, where we're doing a lot of home testing, and I'll come to that in a minute as well. So I'm going to talk to you about EXPPECT, Diamond, Regal, and EPIC2. And as you can see from here, they are all looking at all sort of subtypes of endometriosis. So you may know that there are 3 subtypes of endometriosis. One of them is superficial peritoneal endometriosis. The other one is ovarian endometriosis, like, for example, an endometrioma, chocolate cysts are sometimes referred to. And then you've got the deep infiltrating endometriosis. Now, the thing is, on those 3 subtypes, you may have heard about the severity of the disease. And one of them, the first one, stage 1 is minimal, 2 is mild, 3 is moderate, and 4 is severe. And I'm sorry if I'm, you know, you already know this information, but it's just to kind of clarify as well for anyone who may have not known that as well. The thing that makes endometriosis so complex to understand is that it doesn't correlate. So, for example, you could have really deep disease that's really widespread, and your symptoms may not correlate with what the severity is. So someone who's got, for example, a couple of like spots of mild endometriosis may be absolutely struggling to have any quality of life whatsoever. So it's really difficult to pinpoint and diagnose. And I think that's one of the challenges that we run, you know, when diagnosing endometriosis. Anyway, sorry, I digress. EXPPECT. So we are wanting to determine whether removing superficial peritoneal endometriosis improves painful symptoms and quality of life. We want to know which approach may be best as well. There is a lot of you know, discussion online on whether we should be doing excision or should we be doing ablation, or is this causing more pain and less pain? It's not taking it out completely. So we're collecting that information in the hope that's going to give us an answer. And, you know, we want to find out as well, how often is surgery of no benefit? Some patients experience benefits for perhaps 9 months, and then they have to have a repeat surgery 3 years down the line. And it could actually be making things worse. We see a lot of patients return to clinic with recurrent pain, and we want to find out, have better evidence, because at the moment, what usually tends to happen is if as a clinician sees endometriosis, we tend to remove it. So there's no evidence robust enough to actually tell us that that is the correct thing to do. So we're also doing EXPRI Plus and scanning sub-study, and that's the scanning we're doing in London at the moment, and we're basically having really good doctors who are fantastic at ultrasound scanning, perform ultrasound scans before a patient goes to surgery, and then comparing that to see if that is a way forward with diagnosing, because at the moment gold standard is a diagnostic laparoscopy, and of course it's very invasive and it's a big undertaking, and not everyone wants to undergo a diagnostic laparoscopy, you know, and they might not be in a time in their life when they want to do that either. And then we've also asking patients who consent to the study to give us a blood test, which is again not very invasive at all, I would say, and we are going to be looking at whether we can see from that blood whether endometriosis can be seen, you know, or markers that may actually prevent people from having to have an invasive surgery. So could we in the future be looking at a blood test at a GP surgery? That would be the dream. So that's basically in summary what it is. After surgery, basically what happens is whilst the patient is asleep, we randomize, remember that term, the computer allocates whether it's removed or not, but then the patient is informed that they have endometriosis. They just don't get told whether it's been removed or not. They are still able to access all medical treatments for endometriosis available to them, you know, in the 12 months during the participation. And then we collect questionnaires at 3, 6, and 12 months to see how the symptoms are, if they're better, if they're worse. And after the 12 months, we then ask them what treatment they think they had or removal. And the thing is, I want to walk away from using the word treatment because we don't know if it's a treatment or not. So I'm talking about for superficial disease, is this, you know, the way forward? Removing it is the best way forward or not. And anecdotally, there has been patients who have got that allocation wrong and they say, actually, my pain's become a lot worse, so I think I've not had it removed. And then we find out that actually they have had it removed. And unfortunately, those are those patients that are really disappointed because they think, well, now I've had surgery and it's not improved. Where do I go from here? So that's quite tricky, but it's very interesting is what I'm trying to get at, to be honest. But it just means that this is a really, really necessary and needed bit of research that we're conducting. We're looking at whether we, for 2 to 5 years, whether they have further surgery, whether patients have got perhaps tried for a pregnancy or they've had to seek fertility treatments, and then the symptoms and whether, you know, they have improved or not. Sorry, I should have clicked through. So the inclusion for EXPRI2 is anyone aged over the age of 16, 16 and over, undergoing laparoscopy for investigation of the chronic pelvic pain. However, if you already have a diagnosis through surgery, you're not able to take part. It has to be your first surgery for that investigation, if that makes sense. You could have had your appendix removed or issues with perhaps like an issue with an ovary or a cyst or something in the past, but not actually have had a diagnosis of endometriosis. You could have had a diagnostic laparoscopy that didn't show endometriosis. You could then, and then you were having a repeat one, perhaps 3 years down the line, you can then take part in this. So, and in order to be randomized, the patient has to have the superficial disease in surgery. So that's what's really tricky, because you have to wait until you're in theatre to actually randomize the patient, because we don't know about the superficial disease until they're under and asleep. This is what it looks like if you were going to participate. So we do a telephone call or initial visit. We would maybe approach you in clinic. Could be that the clinician has referred that, you know, your case to us. It could be that you've seen a poster, and I'll come to that as well. So we do questionnaires, diagnostic laparoscopy plus removal, or diagnostic laparoscopy alone. And then we check how you are 7 days later, 30 days, 3, 6, and 12 months. And as you can see, that comes into fruition again, what I was saying with the extra support, because you've got a really good relationship, I feel, with the research team, and they're always touching base with you to check that you're okay. At the moment, progress-wise, we anticipate that we require 908 patients to consent. We did have an original target of 1,200, which is quite an undertaking, but we feel that we've been converting our consents to randomizations and with a better rate than we had anticipated. And what that means is we may approach a lot of patients, they may consent to the study, but as we don't know whether they have superficial disease until surgery, it could be that some of those patients have deep endometriosis, they have other findings like adhesions or problems, you know, with their ovary, or could be scar tissue, things like that, and then they're not randomized, so we lose some of those patients, and that's what the conversion rate that I'm talking about comes from. So in total, we need to randomize 400 participants to give us a really good answer as to whether this is the best way forward, should we be removing it or not. So far, we have recruited 588 patients and we have randomized 158, which I think is phenomenal, especially throughout COVID times. We are currently recruiting at 49 hospitals UK-wide, so if you're calling and you're not in Scotland, I've got a list of locations here. And apologies, that's a really busy slide, but it's just to show you all the hospitals in case you wanted to look at where to, you know, approach the team there for research. Anyhow, we're doing well with that, which is great. The next study, so Diamond is specifically for those patients that have deep infiltrating endometriosis. And basically, just to give you a little bit of background, so you may have heard the term BSGE centres, and those are the British Society of Gynecological Endoscopy. And there are specialist centres across the UK where they ensure that they see patients with deep infiltrating endometriosis. At least, you know, they're doing at least 12 cases, etc. per year, and that they have an endometriosis nurse specialist assigned to them, etc. So the BSG have got this central database where patients with deep endometriosis are entered, and they then say these are the findings. They record their management and surgery details, and then their symptoms are recorded at baseline and at 6 months after the surgery. And we know from this data that most patients benefit from surgery if they have deep disease. However, we do not have a direct comparison to medical management versus surgery. So basically, some patients don't want to have a repeat surgery. And what I mean by a repeat surgery is you've had your surgery for the initial diagnosis. They find deep endometriosis, and usually what tends to happen is they do a really good 360 of your pelvis, and then they don't treat it there and then and remove it, because they then need further imaging. They usually do like an MRI, perhaps an ultrasound, etc., to really locate these nodules and you know, lesions. And then they have a really good team, for example, the colorectal team, that, you know, perhaps if you have endometriosis near to the bowel or on the bowel, then they would have a bigger team, and they have more time allocated to you and your case to make sure that they remove as much endometriosis as possible. So that's what that repeat surgery is meaning, to be honest. So we need to find out whether we should be offering medical management. And some patients are quite happy to be given the diagnosis of endometriosis, and they don't want another surgery because they might want to manage it in a different way. They may have gone away and say, actually, I don't want to put my body through that. So this would be a good trial for you to look into if you would like to. So this is the inclusion. So anyone aged between 18 and 49 who is seeking treatment for pain. So we have to have had a confirmed diagnosis of deep endometriosis with imaging, and also they have to be suitable for surgical or medical management. Of course, like I say, we would never give you something that's going to harm you. That would be the last thing that we would want to do. We are asking you not to conceive in the next sort of 18 months, and then that you've not undergone previous surgery for deep endometriosis. So as you can see, it is quite a tight criteria, and I think that's why it's maybe not been taken up as much as other trials. So this is what the journey would look like. So you would have your initial visit, you would have your laparoscopic surgery and removal of endometriosis, or you would opt for then have the hormonal medical treatment. plus or minus neuromodulators, for example, things like gabapentin, pregabalin, and all analgesics that you may need. They do questionnaires at 12 weeks, 12 months, 18 months, just to see how things are doing with you, really. We've got 22 centres open for the trial. This is also looking for 400 participants. At the moment, we've got 13 participants, but we are recruiting at 22 sites UK-wide. So hopefully that number will increase in the future. So I'm going to go on to the next trial, which is REGAL. So in the REGAL trial, we're trying to find out whether using GnRHA analogues with added HRT. So basically that translates to things like, you may have heard Soladex or Decapeptyl in the past. Some people call it the chemical menopause, but it can really improve the quality of life for some women. Some people think actually it's the best thing. And this is what's so tricky about endometriosis. Not one single treatment suits all. We can only give you kind of like information on how you may benefit or actually, live with side effects whilst the injection is wearing itself out of your system. Some people love it and they stay on it for a bulk of time, where we, of course, would monitor you if you're part of the trial. So basically, we want to find out what the best way to control the pain is, and we want to find out what the best use of NHS resources are as well. So we're hoping to recruit 400 participants to the study, 200 in each arm, and we've got, actually that's not 52 participants, apologies for that. It's 120 that they have at the moment, so that's an old slide, forgive me. And then basically, it's also looking at, should we be repeating surgery? Is that the best thing for people who come back with recurrence of pain? So this includes all subtypes of endometriosis. The inclusion is if you're a female and age 21 to 49, you have recurrent pain following a laparoscopic treatment for your endometriosis, you wish to avoid removal of your ovaries or have a hysterectomy, your doctor considers that you're suitable for both arms, and you're not planning to conceive in the next 2 years, because we would be giving you the Decapeptyl Soladex injections for up to 2 years. We would be looking at doing a little bit more, because with regards to Soladex and Decapeptyl, one of the side effects it can have, because what we would call the chemical menopause, it can have an effect on your bone density. So we need to send you for bone scans. So we do one at baseline, and then one at 12 months, and then one at 24 months. So it's a little bit more of an undertaking, because of course there's more commitment from you as well. But everything is usually initiated from the hospital, and then you just need to go to your GP where they will have been written to the whole, with the whole sort of regimen that you're going to be following. Again, a computer determines whether you go into the Soladex Decapeptyl sort of arm, the injections, or you go down this, surgical route. One of the good things about this trial is nothing's stopping you from, if you get randomized to the surgical route, to perhaps try Decapeptyl Soladex whilst you're waiting. We know that unfortunately waiting times at the moment are between 12 and like 18 months in NHS Lothian anyway, so it could be something that you've tried in the past, but please don't be put off if you've tried it in the past without success. It may be that your body is at a different stage. You always give it a go, and with any research you can withdraw any time. So it could be, actually, Priscilla, this is not agreeing with me, but one of the things that I will always say about Decapeptyl and Soladex is at the very beginning, when you have your first injection, what tends to happen is there's a slight worsening to begin with, and then that's when you see the benefit after a few weeks, that you think, actually I've turned a corner. So it's to bear with the drug sometimes is quite beneficial, but again, we would be there to guide you along the way. So as I say, 120 participants currently and 19 centres. Apologies for that sort of old slide before. And these are the centres that are recruiting. And this has been run by the team in Aberdeen. So we've got some exciting news with regards to the EXPPECT trial. I know a lot of patients have got in touch with regards to this non-hormonal dichloroacetate. You may have heard DCA for short. Life is short. I'm going to keep it short. And obviously I'm going to tell you about EXPPECT 2, which is what we're coming to, but I wanted to tell you a little bit about EPIC and what's got us to EXPPECT 2 just now. So basically, we were collecting samples during surgery to help us understand the disease further. And what we did identify was higher levels of lactate in the peritoneal fluid. And peritoneal fluid is just fluid that sits in your pelvis. It doesn't really have a job as such. It doesn't have a purpose, but in those with endometriosis, it was found that actually this lactate level was higher than those without. So someone very clever, not I, decided what brings lactate levels down? Diclofenac does. So it is an already established supplement and drug. So it's a repurposing of the drug rather than starting from the very beginning afresh where you are developing a drug. It is usually used in metabolic diseases in children and also cancer treatments as well, just to help with side effects of some of the treatments that cancer patients receive. So basically, this first part, which was EPIC, was focused on the safety and acceptability of the treatment itself. And anecdotally, some patients had a really profound effect where others did not. So I'm not telling you this is a miracle drug. This is something that's going to sort you out. This is something that does not have side effects, because it definitely does, but we're trying to mitigate that by doing other things, which I'll tell you a little bit about. One of the really encouraging things is that I feel if it's going to work, it's going to work really well for some patients. And some patients have reported that they were pain-free for 12 months after stopping the drug. So coming off the drug 12 months after. And that is life-changing, I think, for people to have quality of life for 12 months after stopping a drug specifically. So just what we did was we recruited 30 patients with endometriosis and pelvic pain. They were willing to try a non-hormonal, and I think this is what's key here. A lot of the treatments that we offer for endometriosis-related pain and symptoms are hormone-based, unfortunately. Not everyone can take hormones, not everyone tolerates them. It could be that, unfortunately, they've got other past medical history that does not allow them to. So this was really good. So to actually investigate further. At the time, it was 5 visits in the hospital, but then we had to cut that down to 3 during the height of the COVID pandemic. We continued the study, which was great, and we were taking blood tests every 5 visits, and then 3 samples, we collected during the COVID pandemic as well. We found that it was very much acceptable as an non-hormonal treatment. Encouraging results, like I say. I think, on average, patients reduce. So we had pain scores, I am sure you're very familiar with, 0, no pain, 10 being absolute worst pain imaginable. And on average, patients reduce their pain score by 2 points. Now, if you're at 6 today and then someone reduces it to 4, that could be the difference between you actually going into work. We just don't know. I mean, I think 2 points, it sounds little, but it really is not when you're living with chronic pain and chronic issues. We are also, one of the things was that 2/3 of the patients reduced their painkillers and their analgesics. And I think that's a huge achievement as well. So we need to obviously investigate this a little bit more. And at the time when I spoke about this last year, we were looking for funding. We have secured that funding for EXPPECT 2, and the next step is to run the trial. Recruitment, we anticipate, will start mid-2024. So what I was telling you about the blood samples we were collecting, we found that unfortunately most patients did have side effects, and we were thinking, how can we mitigate this? So we run a trial called EPIC+ in between, so that we could actually find out what patients' response to DCA would be. So basically, the 30 participants that we recruited, we found that they either metabolized the DCA really quickly, and those were the patients that didn't have as much of the side effects and effect, a positive effect. And then we had those that metabolized DCA really slowly, and it built up in the system. And they did get more side effects, but they also had more profound sort of relief of the symptoms and positive outcomes. So basically, we recruited 62 patients who very altruistically gave me a blood test and completed questionnaires for me. We collected blood from all subtypes, and then this will hopefully help us really shape the dosing. So basically, what's going to happen is for EXPPECT2, we're going to take a blood from you. We're going to say you're a fast metabolizer, therefore we're going to put you on this sort of tailored dosage. And that's what the hope is, that it's going to help us shape the design of the trial. Needless to say, you may have seen a lot of this online, and it's about the drug itself. It has had a profound effect on some patients, and there is a lot of excitement, and I'm really excited to tell you that obviously we've secured the funding. I have this picture because I love it. It was in The Guardian and it was talking about dichloracity, and I love the fact that it looks like a uterus and an ovary and things like that. Anyway, I put it there because it was quoting the work that we do for Professor Andrew Horne and all the amazing work that he does, and I love the fact that he wants to help patients with endometriosis. Anyhow, I digress. Where we're going to be recruiting, we're going to be recruiting at NHS Lothian and also Chelsea Westminster down in London, 50 participants at each hospital. So please get in touch if you would like to be considered. As I say, it's the superficial peritoneal disease that we're looking for in this trial. Specifically, you have had to have had a endometriosis diagnosis via laparoscopy in the last 10 years. And, it doesn't matter if you take other medication, you can continue to take that. It's absolutely fine. But you have to be able to be under being looked after at NHS Lothian or down south in London. I digress. Other upcoming projects that I've got at NHS Lothian. So we've got EndoFlare. Now, this is looking at, I think, really interesting part of endometriosis that no one really talks about too much. You hear the word flare. Oh, I'm flaring up, I've got a flare. Why are these flares happening? And this is what we're trying to understand further. So we're going to ask patients to provide samples from home most of the time when they are not having a flare, but also can you take samples when you're having a flare, and is there a difference? And these are going to involve a blood sample, it's going to be urine, it's going to be looking at feces, so it's going to be looking at every sort of aspect, and I think it's really interesting. It's going to be run for 12 weeks, and like I say, we're going to provide all the kits that patients can then post their samples into us in the lab, and then we'll be looking at that, putting it together with questionnaires to see what your symptoms are, what the flare is, and then we'll continue to ask you to do that for 12 weeks. We've got EduMed, which is the sample collection that we'd also do in NHS Lothian. If you're going for surgery, you may see one of our faces coming and say, can we please, when the surgeon removes that bit of endometriosis that you so do not want in your body, can we please have a little bit of it so that we can actually use it in our lab for our studies? And one of the things, for example, that came from that was EXPPECT, which is a dichloracity. When we actually applied the dichloracity onto endometriosis lesions in the lab, these shrunk. Now, I know it sounds really exciting. We do not know whether that happens whilst obviously the lesion is in your body, but that could be a trial down the line, but possibly not. I mean, it's really involved, but it's really interesting that obviously it did shrink, the lesions. So yeah, we ask you, please, can we take some samples beforehand, and you complete questionnaires. We love the questionnaires because it gives us a huge amount of information. EndoCan is looking at cannabinoids and whether CBD oil, but not the sort of type that you can buy over the counter. This is more concentrated, more potent. And we know that patients use cannabis and they vape cannabis, or it could be that they are using CBD oil with good effect in the community. So this is actually a trial looking at that, whether administering this oil is actually going to be really helpful and beneficial. Oh, sorry. MacEndo is looking at macrophages and immunotherapy. And apologies for these big words, but basically what happens is your body has got these macrophages, and these macrophages are the sort of cells that regenerate other cells. For example, when you get a cut, macrophages usually go to that finger and they repair the lesion, right? Repair the cut. However, the problem is those macrophages are also present in women with endometriosis, everyone's got them, but these macrophages tend to repair those lesions. So every month when you get a period and your endometriosis lesion is responding to the hormones, they bleed. And then what happens? The macrophages think, oh, I must heal this. And then it heals the lesion again. So we're thinking if we perhaps use immunotherapy, and this is given via an IV during 6 weeks, once a week. So it's quite an involved trial, but it's, again, non-hormonal. Can we quieting down these macrophages and stop them from doing so much repair? Repair is good, and repair is, you know, part of everyone's life, and it needs to happen and biologically, but it may not be as good when you're, you know, your lesions are getting repaired over and over again. You know, can this immunotherapy actually dampen them down and improve on the rate that these are repaired by not repairing as much? Again, it's going to be a little bit tight with regards to inclusion exclusion, because it is a drug that we're going to be giving you via an IV. They're quite involved visits, but again, we run lots of sort of public involvement groups where we ask your opinion on shaping our research and what things we could do to improve the visit. What things do you think would be acceptable? And we've had really good positive outcomes from that as well, because obviously you're helping us shape the future of tomorrow. We also have this Advantage collaboration with Cambridge that's coming up as well. And what we're doing is, this is particularly concentrating on the sort of visceral neuropathic component of endometriosis. And, you know, you may have been told before about nerve damage and things like that. So Advantage is going to be an observational sort of study where we're going to do a lot of testing to try and understand the pain better and your symptoms better. And that's going to have patients with endometriosis, but we're also going to be recruiting other patients out with the gynecology department, where perhaps they have chronic pancreatitis and they have perhaps they've maybe had mesh surgery and things like that, and they're having symptoms from there as well. So that's coming our way as well. Past projects, or ones that are ongoing at the moment, you may have donated your feces, and thank you very much if you've done that. It's not the most glamorous, but one of the PhD students working with us, Francesca Harn-Yates, is looking at whether the microbiome is affected with endometriosis, what things we could do to improve, etc. Just by her presence, she makes me eat better when I'm in her presence. I think I'm not going to eat that, you know, that tray bake. I'm going to have a banana instead. And I think it's really, really important that we're looking at that, because a lot of patients correlate the symptoms, you know, worsening depending on what they're eating, etc. So I think it'll be really interesting to see what the outcome of that will be. And then the other one, which you may have participated or heard of, is Endotech. Now that's coming to the end of recruitment. We're not looking for more patients at the moment, but basically it's looking at patients wearing a smartwatch, and we're looking at fatigue levels, activity levels, and we're correlating that with daily pain, etc. Teo is showcasing her endo tech watch there, very glamorous, very good. She's been a fantastic participant to have in the trial, and I believe that's your last one. And then FAQs. So what if you start participating in a trial but you do not wish to continue? No problem. That you can withdraw your consent without giving us a reason, without your medical care or your rights being affected. Like I say, it could be that we start with really good intentions and say, I want to see this trial through. However, life gets in the way, symptoms get worse. It could be that you say, Priscilla, I'm really sorry, I can't do it anymore. Not a problem. You know, we appreciate you giving us your time, you're willing to take perhaps a drug that's not well known for that condition, etc. And it could be that, you know, your side effects are too great. We would just always say to you, if you're being affected in that way, it might be clinically you're better coming off it. So just I always think, consider research as it should be part of your clinical care, because you need to know that there's an option there for you to take part in something. So I always encourage patients to ask at the clinical appointment. If you need further medical treatment whilst you're in a trial, again, like I say, that we've got really good doctors who are well versed. We are always looking after you really well. If you feel overwhelmed by the prospect of participating in a trial, don't worry. like I say, it's not the right time for you. We appreciate that. Another time will come. And then, you know, if you want to know what treatment you receive, it may be that you're better looking at participating in an observational study where we're collecting surveys, and then we can perhaps tell you, well, this is what we found, rather than being on the blinded category where you don't know what you're receiving. Just something to explore. Again, you want to follow your doctor's recommendation. We always encourage patients, so we always give you what's known as a patient information sheet, and that gives you an outlook, like an outline of what the trial is, the risks and benefits of taking part. And we always encourage you to discuss that with your GP, especially if you've got a good relationship. Take it away with you. We don't, you know, we give you time. We don't have to contact you if you don't want to. You would just say, you contact us if you would like to take part, etc. Pointers to remember. You and your doctor always have to weigh the benefits against the risks, so jointly decide what's best for you. And it's also very important to know that all trials have gone through a really rigorous approval process by an ethical review board to ensure that you're not put under any undue risk. Some trials have got a really strict criteria, so unfortunately there may be some disappointment if someone is looking to take part, and then when we go through the past medical history, or perhaps geographically you don't live in the area, it's very difficult, unfortunately, because you have to be living you know, in the area to participate, specifically if it's something looking at a drug, just to make sure that we can provide you with clinical care if required, you know, so it's always for your safety. Like I say, there's always a good bit of research that will be a good fit for you, and it might not be today, it could be in a few years' time, but it's important to have that good relationship with your research team. You can look at where research is available. Usually we have posters and waiting areas. The clinician may mention, we may send you a letter of invitation to your address, so please feel free to read any information we send you through. And like I say, it's all about offering it to you, so please don't take offense if you get that letter in the post. We've probably really most of the time have looked really deeply at whether this is a good trial for you or not. It could be that your doctor has seen you in clinic and said, I forgot to mention it, so can you send her a letter of invitation? You can self-refer to most trials, and then always say, why not ask at your next appointment? So keeping up to date, you can go into the EXPPECT Edinburgh website, then go into our research, and then under there, you've got all the other research trials that are happening at the moment. You can also go to EndoSOS, where they've got really useful links. And they've got the EXPPECT website to go to. Endometriosis UK have also got a tab on research. So, you know, please go there as well. Also, you can go to scanmedicine.com, and then you can enter your condition, search, and it will filter it down for you. And then equally as good is clinicaltrials.gov, and this one's quite good because you can actually put down geographical sort of like situation. So if you're really remote, I know the Highlands, in particular Scotland, is quite tricky because you are so spread out, etc. So you can put it in your area, and then always remember that every trial usually has the respective website, especially if they're kind of like larger trials where they're being conducted at other hospitals, not just the one, so multi-center, like I was saying earlier on. And then these are the contact details for each trial. So I've put here the Lothian.expect research at nhslothian.scot. It's a really big long email, but that's our generic email address if you would like to find out more about any of these trials. And then if you go to email Diamond, you can also get them at diamond@aberdeen.ac.uk, Regal there as well. I'm coming to the very last slide, and I want to thank you for your attention this evening. Here is my email address for the university and also the NHS one. So if you're going to send me anything identifiable, please, that may identify you, anything that from your medical history that you want to discuss with me, please send it to my NHS Lothian account, which is more secure than the university. We encourage that. And then also you can send it to the generic one. Thanks very much. Just a reminder, it's World Mental Health Day, and endometriosis can be a really difficult condition to live with. So please check in with that colleague, that friend, that family member that maybe has gone a little bit quiet and you haven't heard from them. So thank you very much for your time, and I'm happy to take any questions. I'll stop sharing.
Thanks, Priscilla. I'm actually just going to stop recording now, so then people can put on their screens if they want to. So bear with me. I heard phone. Yeah.